Okay, thank you very much, Scott. That's okay. We will not again waste the time. We will go ahead with the principle of risk communication. We have a great speaker with us today, and I will start with Dr. Kathrin Heitz-Tokpa. She is a social anthropologist working at the Swiss Center of Research based in well, that's in the Côte d'Ivoire, West Africa. But unfortunately, she is not with us. But she will be. She will do it. A presentation will be presented in record format. That means video format. Am I right, Scott?
Yeah, exactly. Adam will share
okay.
After you present.
Yeah. Okay. Yeah. Then the second will be Dr. Djoudalbaye Benjamin, and Benjamin is the head of policy and health diplomacy at the African Center for Disease Control and Prevention, with over 20 years of experience in public health. So we got a lot to learn from him again. And if you need more information about his work, you will have that one. My colleague Scott and Adam will put that one. And he did excellent work in Ebola as well. So in terms of capacity building, we have Dr. Yahya Disu, who is the head of communication at the Nigeria Center for Disease Control and Prevention. And Dr. Yahya will bring on board the rich experience in terms of strengthening risk communication. And I'm sure he worked with our colleagues who are here on board as well, especially in a challenging area in terms of implementing international health regulation. And so he worked in the Lagos State Primary Health Care. So with great experience, again, field experience, we will hear from him. So now I will stop here and I will move on straight to the presentation. Scott, over to you. Thank you very much.
Good afternoon, dear participants. I'm sorry that I cannot be with you this afternoon. My name is Kathrin Heitz-Tokpa. I'm a social anthropologist based in Côte d'Ivoire, Ivory Coast, at Centre Suisse de Recherche Scientifique. I work for the program Afrique One, which is a One Health capacity strengthening program throughout Africa. And we work particularly on rabies, brucellosis, and TB. Thanks for having me. Go to the next slide. We have important gaps in risk communication if we do not conduct CUP studies. We'll come to it in a bit. So you can see here in the 2017 guide, it's really recommended to look at social, economic, political, and cultural factors before going ahead with risk communication. What is a CUP study? K for knowledge, A for attitude, P for practices. We also ask every time for demographic information of people we interview. On the right-hand side, you have the steps to conduct such a CUP study. When you define the scope, develop a protocol, design the questionnaire, conduct the CUP survey, analyze the data, and use the data. Now, what are the reasons really for conducting a CUP survey? It's to identify the level of knowledge, misconceptions, beliefs, and practices in relation to a given disease. But you can also use it at the beginning of an intervention and at the end of an intervention, and to measure the effectiveness of your program. Another possibility is to include one or the other question about the feasibility of behavior change suggestions related to your intervention already in the CUP study, to know how to best design possible preventive measures. Now, what are the questions of such a study? For knowledge, we can say, for instance, can rabies be cured? How can a person get TB? For an attitude question, in your opinion, how serious a disease is brucellosis? For practices, what do you do when a dog bites you? if you had symptoms of TB, at what point would you go to the health facility? You should consider ethics questions before you get started. So research in general requires ethical clearance, or at least a formal exemption from an ethics committee that you do not need one. So generally, make sure you do not harm. People should not be identifiable. Keep your data safe and only collect information that you really need. Now, who to ask? What kind of selection sampling strategies? For a quantitative survey, you generally have the random sampling. Each member of a community should have the same chance to get interviewed, because of course you cannot interview the entire community. You have to make a selection. For a qualitative survey, where we talk about purposeful sampling, you select participants according to different socio-demographic criteria. For instance, age, gender, level of education, profession. For instance, cattle herders, who might be more exposed to TB, for instance, or brucellosis than others, due to their zoonotic characteristic. Our income could also be a relevant criteria for different ways of knowing and behaviors. For qualitative surveys, when you realize that responses you get from the different participants are becoming repetitive, so no new aspects occur, you can generally stop the interviewing as saturation has been reached. I'll briefly give you also an overview of focus group discussion, because if you do not have the time to make a longer survey, at least select people with different characteristics, put them together in a small focus group discussion and ask them your different questions that you have to get a feel for what people think, know, what practices are linked to the particular intervention. These are the different steps. You can read them afterwards as we will share the presentation. When it comes to analysis, you should look at the differences between population groups or between different socio-demographic characteristics. Consider whether that finding applies to the population as a whole, or whether there might be important differences between groups, subgroups. Then also test relationships in the data. For instance, people with a certain religious background may have particularly risky practices or not. Let me give you some examples now from our own research in Côte d'Ivoire on rabies. What came out in a study in San Pedro is that 81% of respondents did not consider rabies to be a serious disease, neither for humans nor animals. 20% said that it is possible to cure a dog with rabies. For humans, almost half of respondents, namely 43%, were certain that a rabies patient could be cured, whereas it's a deadly disease as soon as symptoms occur. So you see, this kind of knowledge will help you to shape your risk communication, your health intervention, will help you to address these particular misbeliefs. Another study on brucellosis in Tanzania revealed the following reasoning now from semi-structured interviews, so from qualitative research designs, where you can get more about the reasoning and why people do things or do not do things. So the cattle herders said, raw milk is more nutritious and causes our babies to gain weight fast and become big. This information we got from a women's focus group discussion in Kilombero. The men said almost the same, but of course for their activities. When we drink raw milk, we can go for up to 2 days without feeling hungry, as the milk has a lot of important nutrients and makes us very satisfied. But once you boil the milk, it becomes just like water and has little value. So much for why they do not boil milk and drink it raw. Now, lastly, let us think about this example from brucellosis further to give you some more data on this case. Out of the 333 respondents, 29% reported that they had experienced abortions in their herds. 14% witnessed retained placentas, and 8% had seen stillbirths in their cattle within the previous year. So these symptoms, they attributed it to trypanosomiasis and to supernatural reasons, but not to brucellosis. Only 7.2% of the respondents had heard about brucellosis as a disease in livestock. Of those 7.2%, only 71% knew that humans can get infected through raw milk consumption. So how to design a risk communication now and a health intervention? What will be successful? Telling people to boil their milk with the arguments of the value of raw milk just heard? Or tell people to call the veterinarians, as soon as they observe abortions, retained placentas, stillbirths? Perhaps this might be costly to call a vet. But on the other hand, you could talk about the economic loss that this causes for the population. So I leave you with this question, and I wish you a very fruitful session, and I hope my colleagues there will be able to respond to most of your questions, but I'm happy to get an email with your collected questions so that I can respond to them. For further reading, I would like to show you the publication from WHO on TB, the first one here on the list, and I think it could be very useful for you to conduct a cup study. All the best. Bye-bye.
Yes. Hello. Dr. Kathrin, this was an excellent presentation, even though you are not with us, and but we could see on the video the pertinence of the communication. And I think, colleague, this is very important, because it is important in the fact that if you don't have credible data, really it is very difficult to conduct or to get the best out of your risk assessment. So without delaying, we will go to the next presentation, please. Yeah. Dr. Djoudalbaye Benjamin, please, over to you.
Thank you very much. And it is a pleasure to be here, and I wish to thank all the organizers for inviting me to be one of the panelists for this important session. I'm not going back to what you have said. I work for the Africa Centers for Disease Control and Prevention. I'm based here in Addis Ababa, and this topic is really timely. It is timely because today we are facing a situation like COVID, and with COVID, we have given what we say in French, the lettre de noblesse of risk communication and community engagement to this matter. So thank you very, very, very much. Now I'm going to take you through what Africa CDC is doing on risk communication and community engagement, specifically when it's come to better response to zoonotic diseases. So you maybe all heard about the Africa News Public Health Order, and this is what we are currently promoting to respond to the current public health emergencies on the continent, including, of course, the zoonotic diseases. And Dr. touched on it yesterday on his presentation, and it is basically 5 things. One is to strengthen national public health institutions on the continent, but not only national, but all our public health institutions on the continent. We also need to really strengthen our workforce development, strengthen our manufacturing, increase the domestic financing, and also respectful and action-oriented partnership. So everything that we are doing is within this framework. Now, we are promoting the one health approach when it's come to the zoonotic diseases, and Africa CDC has adopted and endorsed the framework for One Health practice in national public health institutes in Africa, and it is in the context, of course, of the zoonotic disease prevention and control. And the framework defines One Health approach as a transdisciplinary approach to making Africa safer and healthier for human, animals, plants, and the shared environment. When we look at the data, we are talking about public health, risk communication, community engagement here, and there is no public health without that data. So it is extremely important that we know what we are talking about. In Africa, there has been a 63% increase of diseases spread from animal to human beings for the last decade. And also our population growth on the continent demands for food derived from animals, and this will increase given the weight of our population today. We are dealing with more than 1.3 billion people on the continent. And due to the complexity of the zoonotic diseases, One Health approach requires multiple actors, disciplines, and communities to work in collaboration. That is extremely recommended. Now, our strategy to support member states to respond to the zoonotic diseases are very clear. One, it is the community engagement through the social media, and Africa CDC, we have almost 2 million followers on our social media platforms, and that helps us to monitor and filter online discussions and effectively respond to questions about public health, including zoonotic diseases across the continent. We have also a rumor tracking system and media monitoring to support our evidence-based response to member states to fight zoonotic diseases. We are also doing active monitoring and listening to online conversations and analyzing the trends to identify and addressing the rumors or the misinformation. So still on that one, we are doing a lot of capacity building for our member states, especially on risk communication and community engagement in partnership with UNAIDS, WHO, and other organizations like IFRC. There are many, many more that are joining us in these things, and we are doing it in delivering national, regional, and continental trainings. We have also established what we call the community of practice for risk communication and community engagement, and this is one of the really good lessons that we have learned from the ongoing COVID-19 response. We continuously do a major engagement and we have a weekly press briefing by the director on the current disease in the continent. And this is a platform where reporters can engage directly with Africa CDC and get the questions and clarifications addressed. So this is one of the ways of engaging communities. In support to member states in responding to zoonotic disease, we also built partnership and we put in place e-learning resources for social and behavior change. Africa CDC has partnered with Yale University and Meta to launch a social behavior change learning platform where communication specialists in the different ministries of health can share their knowledge and work on the areas of the behavior change. We also conduct a lot of campaigns with different partners, including public and private entities, to create impactful campaigns. We have also media cafes to better understand the work of Africa CDC with journalists across the continent, because the journalists, their messages got directly to the communities. And of course, we have now, for instance, in the case of the vaccine uptake on the continent, we launched what we call the Bingwa Initiative. And it is a public-private youth partnership to speed up and scale up COVID-19 vaccinations in Africa. And you know that the young people are really very sensitive to misinformation and disinformation. So we are using their peers to get the right information to them. What are the best practices that we have learned so far? You know, in building and sustaining trust is very key. Epidemic start and end in the communities, so it is important that actions of the community members is important to end or sustain an outbreak. It is important to treat communities we work with as partners, and also build trust that we need to listen and we need to act. So this is, in a nutshell, Chair, what I have to share with you on the risk communication and community engagement activities that we are doing here at Africa CDC. I thank you.
Excellent, Dr. Benjamin. Thank you very much for the rich information. You have seen a lot of resources are available. And now the challenge is how to apply it effectively. And with Africa CDC and other partners, we work on the emergency preparedness and response flagship. And communication is one of the key pillars on all the activities we conducted jointly. And without it, it will be really very difficult to promote resilience of health system for emergency in our region and continent as well. So we're going to move to the next speaker, Dr. Yahya, who will talk again about the principle of risk communication in the context of zoonoses. Over to you, Dr. Yahya, please. Thank you.
Okay, thank you very much. And I am most grateful for this wonderful opportunity given for me to make presentation in this forum. And I bring warm greetings from the Director General of the Nigeria Center for Disease Control, who is happily in spirit. So my own topic, I will be sharing Nigerian experience and what we do at country level with regards to risk communication in the context of zoonotic diseases. Well, we understand that Outbreaks, public health emergencies are characterized by challenges, VUCA challenges, volatility, uncertainty, complexity, ambiguity. This as a result of the entity of the outbreak itself. And it also further compounded by conflicting interests from different stakeholders who are responding, right from the forefront to the political class. And the public themselves are not left out in these regards because of anxiety, confusion of what they want to do. We have a motto: the right action by the right person at the right time can save lives. This is similar to the right message from the US CDC. The right message by the right person, by the right time, from the right source, by the right time, at the right time can save life. The difference here is we focus more on action because of our own context in Africa, in Nigeria. Yeah, a message alone is not enough, and you need integrated actions that will involve people to get results. So this next graph shows what I've said. If we have rapid RCC response, timely, and then we're likely going to save more lives. In the context of risk assessment, we know that risk communication is an iterative process for gathering and analyzing information and perception on hazard for risk mitigation. It therefore builds trust in risk management process and acceptance of advice by the general public. We need to also know that this is a continuous endeavor that will start from the beginning of risk analysis and throughout. And one thing that is constant is informed decision-making for every actor that is involved at every stage. And then we need to also note that this will lead to collaborative determination and acceptance of the most appropriate risk management strategy. So we adopted the integrated model for risk communication in Nigeria, which has 5 pillars. But our priorities include the following: robust and resilient risk communication system, science-based, data-driven and context-specific messaging, and a community engagement that encourages ownership and sustainability in a bottom-up approach. And for us to talk about risk analysis, we learned so much about risk assessment yesterday. Risk assessment, just like Professor Morgan said yesterday, is just one of the components of risk analysis. We all know that risk analysis is a collective process that requires involvement of the people to achieve the desired outcome. And because of this, perception of the people is very critical. It's at the central of risk analysis, be it hazard mapping, risk assessment, or risk management. Due to this, it therefore means that risk communication makes or remains a critical component of all the stages of risk analysis, because it considers their values, their feelings, their reactions, behavior, etc. What is also important is how do we conduct risk communication? Do we do it equitably, ethically, and effectively? Do we use participatory approach to involve the people that are concerned? Do we adjust to suit context? Do we use social science methods and tools as well? So, and all will lead to credibility, conviction, acceptance, confidence, and informed choices by the people that are concerned. So this lays foundation for that. So what do we do to gain perception, to get perception? We do opinion polls, just like we do currently bi-monthly for COVID-19 vaccine. We conduct audience perception survey to inform our strategy. And we've done that for COVID-19. We are doing that for monkeypox now. Then we also look at our rumor log to get insight as to what could be the perception of the people. And that leads us to understanding the risk in the context of the people from their perception, and then apply communication theory and model to determine risk communication strategy. And this chart, I'm sure some of us are familiar with this. These are the options based on the data and the communication model we are using. So we have a national Nigeria infodemic management team that is One Health based, that meets weekly and then uses tools to get information on from social media, from all sources. They triangulate this, and then they use tools to guide them in actions and decisions they make. And they come up to produce weekly infodemic trend reports from which messaging priorities are gotten. And they also generate insight for policy making, responders, EOC, and so on. And this is our message flow that we use for developing messages. And these are message dissemination strategies. Our message dissemination strategies use mix of approaches. And our infodemic management team also measures and monitors reach, understanding, acceptance, utilization, impact. This is a chart to exemplify what I've just said. Number of key messages, priorities recommended, how many were actually developed, and what are the channels, and we can see. So with regards to One Health approach, NCDC Nigeria has adopted a One Health framework for our preparedness and response. And in the area of surveillance, we have human-animal information sharing, then the research survey on monkeypox in small mammals. And then we've also had capacity building across the benefiting from African CDC One Health training program in Dakar recently, capacity building on joint risk assessment last year, review of priority zoonotic diseases we did about 2 months ago. Our National Risk Control Technical Working Group is based on One Health, and we have also developed RCC training module piloted last year. So our AMR control program is also based on One Health. Key functions required for successful One Health approach to risk includes coordination, collaboration, and communication. And accountability is also central to this. So, and we've had a multi-hazard guideline we developed that guide what we do. We have training module we have developed. Our quarterly meeting produce reports, recommendation, and platform where we share information. And also we have a bulletin across the stakeholders. I mean that capture development from stakeholders. We have a maiden bulletin to come out. Then these are also bulletin One Health knowledge management platform that were created for risk communication stakeholders. And we're using human-centered design to pilot in states endemic with Lassa fever. We now want to promote bottom-top approach in what we're doing. We have had world conferences and so on and so forth. And their basic principles are used. So lastly, I will quickly tell us about what we do for monkeypox as an example. When the current outbreak globally, when it was reported, we set up, we had a press release and following our risk assessment. And then again, we continue to monitor the media to follow, to understand what is the trend. And then we conducted monkeypox survey to understand the perception across the nation. And these are the findings. And after the survey, we're able to also, we continue to monitor infodemics, and we're able to come up, organize a workshop for developing SBC material, and then develop jingles as well as posters and other messages that go for our social media. Then infodemics, we dealt with a situation where Russia claims that monkeypox originated in US control lab in Nigeria. We work with our stakeholders to do that. And then we did media dialogue and trained the media on what to do. Antimicrobial resistance is also what we do awareness week. We participated in the Ministry of Agriculture and Environment to synergize. So next step for One Health Nigeria, advocate for risk communication to be included in the thematic pillar for investment under One Health coordination structure, so that I will get attention it deserves. Build capacity of veterinary officers and other actors on risk communication. We're planning this next week. FAO is supporting this. Increase advocacy and awareness creation for One Health events and prioritize diseases among stakeholders and general public. And scale up training of One Health spokesperson and media in 3 states, because we have started training on media engagement, One Health stakeholders using the module. We are going down to the states now. So, and the challenges include aligning many stakeholders with differing needs, priorities, and mandates, and misinformation resulting from conflicting messages from different stakeholders. Encouraging adoption of 4-pronged approach to stakeholders engagement, which include development of sector-wide guidelines, provide technical assistance, provide update information and feedback mechanism, adopt all of society approach to infodemic management. Thank you very much, and I will be ready to take information. Next questions. Question and answer session.
Yeah, thank you very much, Dr. Disu. Really, another brilliant presentation. And colleagues and ladies and gentlemen, you have seen the 3 brilliant presentation about all the principle of risk communication in the context of zoonoses. But having said that, really it is crucial that these principles are applied rapidly, because the rapidity of the assessment is paramount as well to disease control, whether it is emerging or it is endemic diseases. So, and we also, for your presentation, the three presentation, we have looked at the question and answer chat if there are burning questions. So we gave you 2 minutes, colleague, if you have burning question, and we can address them before moving to the next session. And Adam, have you seen some question? Because the question I have seen, I think a colleague asked, what is the role of One Health in surgery, if I understand well? Again, I will address that one. I will not pass it to any speaker. But if you want to complete, you can. I'll always do that. The collaboration between medical and veterinary sector, that form really the backbone of One Health. If you look carefully what virtual say, and so it is important to understand. We learn from each other. Each sector has, it is kind of for the subject matter expert, but the crossroad is very narrow. The interrelationship is very narrow. It's not wide. And so you probably learn from primary school, the biology about the insect, about the plant, about the animal, about the human. And at the end of the day, you practice on animal before even using a human body. So we learn the rich experience you learn from that, and that information is shared. So it's not really rocket science. And even vaccine development, why we got a vaccine quickly in the COVID, it is because the knowledge which we had in the past. And so those available tools, they were used directly. So for surgery, again, you can go and read a little bit about it, and you will see there is a lot to share between those sectors. And so, and for record and presentation, they will be shared again. And there was a request about the certificate for pass the training. Again, there is always a requirement on those ones. But at the end of the day, thank you again for your participation, and you have seen how it is important to have credible data and from different sources. And it doesn't need to be really, even if it's not much, but it needs to be good quality to be able to make good decision. And this decision, again, it is dynamic. Things change overnight. Things can change. So you need to keep up to date. And so I will stop here unless there is a burning question in the chat box. Adam, please, could you cross-check that and read out the question?
Hi, Tieble. I see there's actually a question from Claudia Fernandez here. She says, do you include an assessment of environmental health and the drivers of zoonotic disease spillovers in your risk assessments? So maybe you can approach this more in the risk communication parts.
Oh,
the role of environmental health and the drivers of zoonotic disease spillovers.
Okay, so Dr. Benjamin, and if you would like to take that one, or Dr. Yahya, if you want to address that one, then we can complete, we can top up. Thank you. If there is a need.
Yes, it is something that is being taken into account in the assessment of zoonotic diseases. So, but it is a work that is being mostly done at country level. But if you go and check, the framework that we have, this component is well captured. Thank you.
you very much, Dr. Benjamin. You're quite right. And yesterday you have seen the tool called Joint Risk Assessment Tool. And that tool has been developed to support the multi-sectoral coordination mechanism at the country level and to bring experts from environment, academic environment as well, and animal sector, human sector, security, and all those who can provide information and exchange it. So it is taken into account. And some diseases are vector-borne diseases, and you need, again, meteorological data even to predict when that will happen. So it is well taken on board. It is well considered as well.
Hi, Tieble, I see also another question here that they're asking that often it's the medical doctors that are put at the center of public health response, and veterinarians are often neglected or ignored. So how do we expect an effective intervention when certain actors are excluded?
Okay, thank you very much. Right, okay, yes, okay. We are actually risk communication, and you have seen those sectors. They are all called upon to give their opinion, their expertise, whether it is veterinarian or environmentalist. But I leave the presenter to cover it, and if there is need, we come to that. Dr. Yahya, you want to take that one?
Okay. For instance, in Nigeria Center for Disease Control, we do not consider whether you're a doctor, whether you are from environment. We all work together. The framework that we have adopted is the One Health approach and multi-sectoral, multi-partner technical working group. And in a situation where we have activated EUC, we extend the same principle. So, and then we always work together to go to the team and to also encourage the state to work with the Ministry of Environment. I remember recently, in 2020, when the Middle Belt part of Nigeria, where people were serious deaths, and epidemiologists that visited the place could not pinpoint what is causing this. Ecologists, they have to bring in environmental experts, and as well as people from health. And they went to Benue, and they were able to get information that before they started recording human death across the riverbank that died around December, the deaths were recorded in January. So when they investigated, they found out that they were to catch many fish, and because of that, they pour some chemical in the river. It's by our surveillance and our event-based surveillance, and it was flagged to Ministry of Environment to go and investigate. That was in December when fishes were dying and started dying. So we require that collaboration for us to be able to get to the bottom of the matter and engage the community to ensure that things does not happen again. So, but it may look as if it's dominated by human health, but there is progress. Who can also testify to what we do in Nigeria. Thank you.
Fantastic. Thank you very much. Really, this is a good example. And I think we will move on to the next presentation, next session. But colleagues who are really interested in that, the veterinary sector is not excluded in One Health approach at all, because one of the main reasons is the veterinary sector conducted performance evaluation for veterinary services, and the main purpose is really to improve that one. So a disease, animal disease or zoonotic disease, or even food safety, all can be addressed. All can be addressed appropriately. So it is key in the implementation of International Health Regulation 2005. So, and global health security as well. So it is, there is no exclusion at all. And we do conduct a lot of workshops and to support member states, and that is done with all the partners to implement a really strong, robust, multi-sectoral coordination mechanism. And it depends where you come from, really, if you can liaise with your colleague, if you're interested or to be involved in, there will be always opportunities.